Hello, it's great to be with you all here today. I'll be presenting on making psychopharmacology easier in the trenches. Yes, there's an app for that. A presentation of the Waco Guide to Psychopharmacology in Primary Care. Brief introduction. My name is Ryan Laschober. First and foremost, I'm a practicing family medicine physician, but also serve as program director for Waco Family Medicine Residency and editor-in-chief for the Waco Guide. Over the next 30 minutes, we really want to accomplish three things. First, review the role of primary care in the behavioral health landscape. Then introduce the Waco Guide as a key evidence-based tool for use and practice. And then lastly, go through a few case studies of using the Waco Guide. As far as disclosures, we have no financial disclosures, but also like to highlight that these tools were created free of industry funding and are free to access as well. Thank you to many of our grant funders. So picture yourself in clinic tomorrow. Think of a 67-year-old who walks in your door with a new diagnosis of major depressive disorder, or a 14-year-old female with severe generalized anxiety disorder and failure to respond to max dose fluoxetine. About a 28-year-old male, status post of delirium tremens hospitalization secondary to alcoholic cirrhosis, requesting alcohol abstinence pharmacotherapy and treatment for major depressive disorder. Or a 31-year-old G1P0 at 12 weeks estimated gestational age with a past medical history of bipolar disorder, hospitalized for mania 6 months ago, and currently euthymic, not on any medications. I think we can all agree that we could see any of these walking in our door tomorrow. And many of us listening to this now would have various levels of confidence in treating these individuals. And what we really want to share is the Waco Guide to Psychopharmacology and Primary Care as a key tool to treat all of these individuals and many more. The Waco Guide is a combination of top-level evidence and expert opinion, all tailored for primary care. So let's start with the behavioral health landscape. We know a few things. Evidence tells us a few things, that most patients enter care for mental illness through primary care, that 80% of patients with a behavioral health disorder have seen their PCP in the last year. And for PCPs treating those behavioral health disorders, they lack access to specialty services. And so if a PCP would like to refer their individual, their patient they're taking care of with a behavioral health disorder to specialty services, 2 out of 3 PCPs said they could not. And this care gap is amplified and worsened in underserved communities, both in urban or rural settings. When it comes to treatment, most patients receive treatment for their behavioral health disorder in primary care. And most PCPs the majority of PCPs will report that they feel underprepared in this role. But lastly, and what could be really encouraging, is that we know that when knowledge and scaffolding are put into place, that we can see excellent treatment outcomes. And so, like many, reviewing all this, we've sat there and asked ourselves, how can we provide high quality care for behavioral health disorders in the primary care context? We looked at multiple options and really landed on decision support tools as a key intervention for treating behavioral health disorders. And so next, I'll share a little bit about the clinical decision support tool for psychopharmacology, really that developmental process. Like any good clinician right now, I hope you guys are feeling two feelings right now. One, excitement for a tool that may impact patient lives, but also a little skepticism, being skeptical that what I'm sharing today has rigorous evidence, review, and should be a process that you can trust. So let's first share a little bit about the components of a decision support tool. First, these include algorithms. These are logic to complement your routine medical decision making. Next, they include prescribing info. These are dosing, titration schedules, and monitoring parameters. And then lastly, strength of recommendation ratings. When we were envisioning creating these tools, we really had a few key principles that all these tools should be guided by. First, they should be reliable. They should have top-level evidence, expert opinion, and all tailored for real-world primary care experiences by real-world primary care clinicians. They should be succinct. These tools should be used both inside and outside the exam room, but really where you can pull them up while discussing with the patient, and should be respectful of cost and funding sources. Like we see in primary care, they should be expansive for the whole scope of what we see walking our door. So it should be able to treat pediatric, adult, perinatal, geriatric disorders, and should all be ethical and specifically not industry funded. When creating these tools, we really wanted to turn to a key colleague, key partner in creating these tools. And so these tools were created by faculty of Waco Family Medicine in consultation with the faculty at Massachusetts General Hospital Psychiatry Academy. So peeling back the curtain a little bit on how these tools are created, because I think it really lends to the credibility. First, the Waco Guide team combined clinical guidelines and high impact literature to create a first initial draft of the tools. This was created by a clinical psychologist and a psychiatrist to create that first draft, and then went before at least 2 family medicine or primary care clinicians, really to review the tool and lend the primary care lens to that. That tool was then taken to 2 independent expert consultants at Harvard, Massachusetts General Hospital Psychiatric Academy to again review that evidence and the application for it in primary care, and a final tool was then created. Earlier, I said primary care clinicians because I also want to highlight that, especially in perinatal areas, that we would either have a maternal fetal medicine physician or an OB/GYN join us for those conversations as well in creation of those tools. As you all know and see every day, our patients don't exist in isolation. Comorbidity is often the rule rather than the rarity. And so these tools are then individualized for the different comorbidities we may see. So cardiac impairment, hepatic impairment, and renal impairment. We also are then standardize these tools for women of reproductive age, geriatric, pediatric, and obesity populations. And all must have fidelity to best evidence. And so many of y'all are familiar with the strength of recommendation taxonomy, A through C, where A is recommendation based off consistent, good quality, patient-oriented evidence, or C may be recommendation based on consensus expert opinion or disease-oriented evidence. All of this information is then combined into the Waco Guide to Psychopharmacology in Primary Care. This is now a collection of over 100 decision support tools, really guiding the routine and advanced behavioral health disorders that we will see in primary care. These tools have grown quite a bit now. They're used nationwide, and their use is supported by the American Medical Association and the American College of Physicians. The Waco Guide can really be accessed in 2 ways, a website and an app. And what's neat is most of y'all listening to this, if not all right now, listen to this, both have a computer in front of them and a phone to the left or right now, like me. And so I encourage y'all to either grab your phone, pull it up on the computer as we go, because I really want this next part to be interactive and you practicing using the tools. I'm going to start with the app here, the wacoguide.org. And I'm actually, I'm recording this on March 7th. Our new updated website will be released in the next week or so. And so the goal is that by the time you're reviewing this, you see this new updated website. So I'm going to share with you the new updated website. So if I click on that Waco Guide there, here's a new website I'll see. And there's 3 big landing buttons that you'll see: this step-by-step guided tool view, comprehensive tool view, and additional resources. And I'd like to walk through those together now. First, that comprehensive tool view, I'll see the long list of behavioral health disorders with guided treatment principles here, everything from major depressive disorder to OCD here. If I look up at the top, I can see and filter by multiple different populations. So perinatal, geriatric, substance use disorders will really zone in on those different tools there. But if I go back to all tools, let's walk through one together. Let's look at generalized anxiety disorder right here. Click on generalized anxiety disorder. You can see the different tools and subpopulations which are addressed, but let's just stick right now with the general adult generalized anxiety disorder. Click that here and you'll see a kind of algorithmic based approach for treating GAD pop up here. And we're going to walk through this together to really highlight these different treatment steps and principles. There's a color key off to the left which guides what these different colors show. First is gray is your title. Blue is pre-pharmacotherapy questions are really going to guide potentially your pharmacotherapy, such as do they have comorbid depression? Red is going to be that first line pharmacotherapy options. And then green is that second choice, second line pharmacotherapy options. A lighter green is available here for partial responses, really showing the augmentation therapies that are available and recommended. And then our hope is to reach purple. This is an adequate response that will really guide how long we should continue an effective pharmacotherapy and when we should provide a shared decision-making discussion of tapering a medication. You can see again these sort statements here, sort A, sort A, sort A for the strength of recommendation here of these different treatment principles. The 2 colors I haven't highlighted yet then are orange, which is non-pharmacotherapy directed recommendations, and then a bright blue, which isn't seen on this tool, but at times will be that kind of third choice pharmacotherapy options. Across the top, then you also see medications listed here. I can click on that and see in an alphabetical order by class of all the different medications included in this tool. So let's say for the patient at hand, we landed on treating them with escitalopram. I can click that here. See the class, brand names, starting, titration, and max dose options there. Also side effects, common, rare, as well as monitoring parameters and any additional information like here it includes the black box warning that exists for escitalopram. Then lastly, I can click references across the top. And this is that strength of recommendation table here, where you can see that, starting off here, that we should consider CBT for the treatment of GAD. Now I can reach this guided view both on the homepage or right here, but I'm going to click it here so we can then see how this may look in a different setting here. So I'll click guided view. This takes all that algorithmic logic and puts it in more of an app-based logic here. And so you can see that pre-treatment question, does the patient suffer from comorbid depression? I can click no here. And then I have the option to click if they're currently or previously taking any medications. So I can say currently taking a medication. And let's say they are currently taking escitalopram. It's current here, and they've had an unsuccessful response. How should a true response or trial be viewed? It's always going to say at the top what an adequate pharmacotherapy trial is. So for GAD, an adequate pharmacotherapy trial is a minimum of 6 to 8 weeks at a maximally clinically indicated and tolerable dose. So I've selected escitalopram, current unsuccessful response here. I'll scroll down the bottom, and I can receive a tailored recommendation for this patient of change to buspirone or a different SSRI or SNRI. I can scroll down here, click on one of those other medications like sertraline. Again, see specific dosing recommendations. Up at the top there, I could click on the sort table. It'll pop in again to see those strength recommendations. And I can click on the algorithm here as well. How I got there again was that guided tool view button before, but really where that comes into play is a step-by-step guided tool view. That's what y'all just saw. Again, I can click that here, and this is just a little bit different view to get to where we just were, where I could, again, scroll down, click generalized anxiety disorder, adult, no special populations right now, no comorbid depression, and you can see it just moves to the tool just like before. Lastly, on the homepage, I want to highlight this additional treatment resources section. This is a section that many individuals have really grown to appreciate in their practice. I'll click that here. It includes 4 areas, some specific calculators that are used in care on a daily basis, medication switching guides, antipsychotic side effect management guides, and then a whole overview of all the medications. Starting with calculators, you can see here, these are calculators that may be used to guide treatment principles, such as Child-Pugh calculator here to really determine, I'll click through randomly here to get a Child-Pugh classification here, a Child-Pugh class B. This may guide pharmacotherapy choices later. Scrolling back to the top here, medication switching is just something that we see many clinicians use every day now. And this is really taking 2 medications, such as I'll click on antidepressant switching, where let's say I had a patient right now on sertraline or paroxetine, let's say sertraline here, and I wanted to switch them to venlafaxine. I can click that and receive a specific evidence-based recommendation of how to switch this medication, such as cross-taper medication over 1 to 2 weeks. Moving back then, we can also do the same thing for a mood stabilizer here. If I'm switching somebody from carbamazepine to lamotrigine, it'll tell me exactly how, from an evidence-based standpoint, to do that. So there's sections which are really helpful here, antipsychotic management here. So I can click on, let's say somebody has a movement disorder from their atypical antipsychotic or typical antipsychotic. I can zoom in on akathisias, how to treat that specific side effect from an atypical antipsychotic, medications that may be used for that, and again, references there. And then moving back here to metabolic and medical disorders. So what about a patient on an atypical antipsychotic with weight considerations here? Same like before, I can click guided tool view and it can ask me those same questions. What about if somebody had a metabolic related disorder and weight gain? I can start kind of walking through and saying, how should I treat that individual further? And then lastly, again, on the additional resources section will be medications. This was where I can scroll through all the medications that are utilized in these decision support tools and zoom in on their dosing. For example, here, if I wanted to scroll in on somebody using let's say an SSRI here, and scroll up and click on escitalopram and see all the different places where it may be utilized. So we're looking at generalized disorder, but the question would be, should the dosing be different for obsessive compulsive disorder? This is here used in an antepartum domain. It'll give specific OCD antepartum recommendations there. Another example is for panic disorder in an adult population, what should be utilized? So that's the main overview of the website. I'm going to switch back to the presentation here now, and we'll look at the app a little bit. So the app is just like before. It takes all of that algorithmic logic and turns it into app-based logic. So y'all can scan that QR code if you want to download the app now. For Android users, it's coming soon. You can use the app-based logic on the website now. Hopefully in the spring, summer is when that'll be available there. So let's walk through using an app. This is a similar format to how you all saw on the website, where first I'm going to input a diagnosis, then click on the age, and then any special populations. Then you can see that here I chose post-traumatic stress disorder, adult, and did not choose any special populations here. It'll then just ask me a few pre-treatment questions. Does the patient suffer from clinically significant hallucinations? Does the patient have a comorbid sleep disturbance? So I'll click no to hallucinations, yes to a sleep disturbance. It'll ask what type of sleep disturbance. So this patient's having nightmares, or having mid-sleep awakening or nightmares. I'll then input if they've had any prior medications used to treat this disorder. None now. I won't enter any now. And then the next gives me a specific tailored recommendation. Start an SSRI or SNRI. Also recommended trauma-focused psychotherapy. And then moving forward, it'll have all those recommendations below. I can click on therapy here and look at the different recommended therapies to consider as well, recommended therapies or consider therapies, the different recommended trauma-focused psychotherapies. I can also click on that sort statement at top, and it'll give that sort table, that strength of recommendation table there as well. And then at the bottom, when you use the app, you see I clicked in blue, that resources section. That again includes the antidepressant switching, mood stabilizer switching, all the calculators that we saw before. Let's move through a couple cases then, now practicing using the tools. I recommend y'all having your phone or computer out and us doing this together. That's why we're doing it here. And so let's start with Samantha. You'll recognize her case. She's a 14-year-old female. She's been seen for the past 4 months for debilitating generalized anxiety disorder that negatively impacts her academics and friendships. You've ruled out alternate etiologies of symptoms through a history and physical, and she denies suicidal, homicidal ideation, auditory visual hallucinations, or mania. She has a family history positive for GAD in her mother. Given her symptom severity, Samantha, her parents, and you all collaboratively determined that pharmacotherapy and a referral for CBT is in order. You start fluoxetine and titrate to max dose. After 8 weeks at max tolerable dose, she's had an inadequate response. So what pharmacotherapy would you consider next to treat her GAD? So in summary here, it's a 14-year-old female. She has severe GAD, and she's failed to have a response to fluoxetine. So let's move through using an app. Using the app here, I can select the disorder, generalized anxiety disorder. I'll scroll down here, choose pediatric, no special populations there, choose severe, and then she is on a medicine now. She's on fluoxetine, it's current, and it's unsuccessful. I'll scroll down now, click next, and get a specific tailored recommendation. I can scroll down and click on the dosing here for escitalopram. It's exactly there, and then click on the table as well, and then I'll show the algorithmic table here if I'd like to look at that too. So y'all can see I moved through that quickly, but in just about 15, 20 seconds, I can receive a tailored recommendation for a patient at hand. Let's move on to a little bit more complicated case. This is Miss Jones. She's a 38-year-old female you're seen in clinic for a hospital follow-up for delirium tremens. She's completed an inpatient benzodiazepine taper. It was referred for a 12-step program upon discharge. She has a past medical history significant for hypertension and alcoholic cirrhosis, child PU class B, and that was actually just diagnosed this hospitalization. She's had 2 children and is status post-tubal. This is her first hospitalization for DTs, and she's motivated for long-term alcohol abstinence. She asks if pharmacotherapy would be a reasonable option for assisting her in cessation. Using a Waco guide, how would you guide her further? So I'm going to pull on the website again here. Let's use this comprehensive tool view this time. So I'm going to click there. Here's alcohol use disorder in an adult. The algorithm is going to pop up. You'll see 2 sides to here. Here's alcohol withdrawal management. She already completed that with a benzodiazepine taper in patient, and now we're in the post-withdrawal period. It'll first say evaluate and treat for comorbid mood disorders. We'll do that in a second, as well as refer to a 12-step program, which has already been done with great sort of evidence there. Then we can consider pharmacotherapy. And the question here is, does the patient have a subgroup indication or contraindication? If no, then often it's going to just trend towards using naltrexone here. But actually, she has hepatic impairment. She has Child-Pugh class C sclerosis, and so we're instead going to use acamprosate here. If it's been a day or two since I last prescribed acamprosate, I can click up at medications at the top, review the dosing and titration schedules here. And then also, again, click on references to receive those key references. Let's now return to our case here. So in addition to alcohol abstinence pharmacotherapy, you and a behavioral health consultant perform a psychiatric evaluation. Miss Jones reports a multi-year history of severe MDD and anhedonia. She denies mania, AVH, SI, or HI, and you diagnose her with severe MDD. She has a PHQ-9 of 21, indicating severe symptomatology. You discuss multiple treatment options and via shared decision-making decide on combination CBT and pharmacotherapy. She recalls being treated for MDD 10 years ago with sertraline, but had little to no effect after 12 weeks at maximum dosing. Using a Waco guide, how would you guide her further? So again, on comprehensive tool view here, I can go click on depressive disorder, but now she has hepatic impairment, so I'm going to click that there. And you'll see a specific tool that pulls up here with some new yellow triangles here, because that may dictate a little bit of our pharmacotherapy adjustments here. So here's treating major depressive disorder. It's severe. We should do combination psychotherapy and pharmacotherapy. And first trial antidepressant should be an SSRI or an atypical antidepressant. I can then click on medications here and look what SSRIs are recommended. And some of these have specific signs that will pop up here. I'll click on escitalopram first. That'll give me some tailored dosing recommendations. I can also click on sertraline, but actually sertraline only has Child-Pugh class A recommendations and is recommended to avoid in Child-Pugh B and C. So let's not use that. Maybe instead we'll choose fluoxetine here. Fluoxetine, you'll see it start at 10 milligrams now, and the max dose is 40 milligrams because of her cirrhosis. Let's finish out this case then. Miss Jones was started on fluoxetine and titrated to a max dose of 40 milligrams. This is a max dose for cirrhosis. She's now been at max dose for 8 weeks, resulting in a partial response, which is reflected in a PHQ-9 decrease to 14. She feels fluoxetine has been a beneficial medication for her, and desires further pharmacotherapy. Using a Waco guide, what pharmacotherapy would you choose further? So let's look here. Here's that same tool we looked at before. Now I'm going to zoom in on this partial response node here, continue the current antidepressant and augment. And our two first choice options are aripiprazole or add an antidepressant from an alternate class. So in this situation, if we're on an SSRI, we'd add mirtazapine or bupropion. So let's say we go ahead and add aripiprazole in this setting. All right, hopefully that was a great crash course in using the Waco guide, and really hope that you can see how quickly you can receive a plethora of guidelines, evidence, expert recommendation, all in a tangible fashion in the exam room. Just want to highlight a few future goals. First of all, definitely for you Android users, again, want to have the Android app hopefully later this spring or summer. At the time of recording this, our updated website should be live, and so excited to have that there available now. Also, for those who like these decision support tools in a book format, it should be available on Amazon later this spring. We provide continuous app review and logic review of all our tools here. So every tool is reviewed at minimum every 2 years with us and our Massachusetts General Hospital psychiatry colleagues, but as well as we perform continuous review with consultations every other week with MGH here. Lots of tools that we'll continue to develop in the future, such as non-pharmacologic tools, neurocognitive symptoms of dementia, and many more. One of the beauties of an audience such as y'all and a tool such as this is the real-time peer review. And so we love hearing from y'all, recommendations, things that may be more useful in your practice. We'd love to hear that. Y'all can reach us both through the website and the app, or follow us on Twitter or Facebook, where we kind of have routine releases of information that may be helpful to have kind of that continued education piece. It was great being with y'all today. I really enjoyed being able to meet with you guys. Hope to hear with y'all further in the future. Have a great day. Take care. Bye-bye.